A very, very good evening, Honorable Chairpersons, respected panelists, dear speakers and learning audience. I am Dr. Dipal K. Adhikari. Welcome you all to this evening's webinar, jointly organized by Department of Cardiology, Bangabandhu Sheikh Mujib Medical University and Bangladesh Cardiovascular Research Foundation, with the technical support from Incepta Pharmaceuticals Limited. Today, a galaxy of cardiologists from home and abroad will illuminate us. I feel very much delighted to introduce Professor Supiya Rahman, Professor Syed Ali Ahsan, Professor Shajal Krishna Banerjee, Professor A.K.M. Fazlur Rahman, Professor Chaudhary Mishkat Ahmed as chairpersons, and Dr. Kaisan Nasrullah Khan, Dr. Dhiman Bonik, Dr. Ashok Datto, Dr. S.M. Ahsan Habib, Dr. Muhammad Abu Salim, and Dr. Muhammad Mukhlisur Rahman as panelists. Today we have two eminent speakers from India who will speak on two separate issues in cardiac interventions. One is from South India, Dr. Karthik Vasudevan, and another from West Bengal, Dr. Kuntal Bhattacharya. Two exciting cases will be presented by two youngsters, Dr. Muhammad Fakrul Khaled and Dr. Chayan Singha, both of them from BSMMU. Now, as usual, I will invite Professor S.M. Mustafa Zaman, President of CVRF, Bangladesh, for his welcome address. Professor Zaman, please.
Thank you, Dr. Dipal Krishna Adhikari, for introducing me. Actually, I'm very delighted to have all of you here. And respected chairpersons, we have Professor Emeritus Supiya Rahman and Professor Syed Ali Ahsan, Professor Fazlur Rahman will join very soon. But we have Professor Shajal Banerjee. He always actually with us and gives some inspiration. Dr. Chaudhary Mishkat Ahmed and two speakers from India, Dr. Karthik Vasudevan and Dr. Kuntal Bhattacharya, two young stars of our speakers presented, Dr. Fakrul Khaled, Dr. Chayan Singha, and we have learned actual panelists, Dr. Kaisan Nasrullah, already he joined, Dr. Dhiman Bonik, already he joined, and Dr. Ashok Datto, Dr. S.M. Ahsan Habib already joined, Dr. Muhammad Mukhlisur Rahman, Dr. Abu Salim already joined, and thank you all and good evening and welcome you all in this session. And we hope we'll enjoy this session as before and we'll increase our learning curve after this. Especially the topic was actually very, very interesting topic, and our case presenter also they will present interesting case. And we actually would share our knowledge, and after this, it will be enjoyable, I think so. And thank you all again, and start and go ahead. That's next presentation also, Dr. Dipal Krishna Adhikari. Thank you also.
Thank you, Professor Zaman, for your excellent job. Now I will invite Dr. Fakrul Khaled, Assistant Professor of Cardiology, University Cardiac Center, Bangabandhu Sheikh Mujib Medical University, to come up with his case, DK crash in Non ST ACS. Dr. Khaled, please.
Okay. Assalamualaikum, sir.
Walaikum salam.
Sir, it is my pleasure. It is my pleasure, and I feel blessed to be in front of my respected teachers and learned expert from home and abroad. Here I am going to present a case of complex intervention that was performed by my professor S.M. Mustafa Zaman in our cath lab, and I was with him. And our case, a 63 years male, hypertensive for 15 years, presented with chest pain and severe sweating for 2 hours. His ECG showed ST depression in V1 to V4, and bedside echo shows anterior wall hypokinesia with reduced ejection fraction 45% and diastolic dysfunction of grade 2. Troponin was raised by 1.38 nanogram per deciliter millimeter, and serum creatinine was 1.3. As we performed his risk stratification in Non ST ACS, TIMI score showed 4 and GRACE score more than 140. That is, that indicates high in-hospital death of more than 3%. So we preferred early invasive strategy for this patient. And his coronary angiography showed the findings. There is the left ventricular descending artery, and it is a significant lesion in proximal to mid part involving D1, and the bifurcation lesion Medina 111, and right coronary artery shows mild disease in the mid part, and CT score was 18. So what should be our intervention strategy in this case? Single stent strategy, which is preferred in ACS setting, but there is significant side branch. We don't want to lose it, and there is less thrombus burden. So two-stent strategy is considered. We considered him for two-stent strategy, and which techniques? DK, Dept, or others. We prefer DK crush, as it's straightforward, reliable, safe, and effective for complex tube bifurcation, and provide significant better sideline coverage. And angle was it can allow in all bifurcation angles. So we prefer DK crush. At first, we put wire on both LED and diagonals and make predilation of the side branch with 2 into 20 millimeter balloon at 14 atmospheric pressure, and then main branch was predilated with 2 into 20 compliant balloon, and we put a stent on the side branch 2.25 into 18 millimeter graduating stent balloon, keeping the balloon in the LED distal to D1. We put the balloon to D1 and put a stent on the diagonal first. This is the then we remove the wire and balloon from the diagonals and put a stent on the then first we crush the side branch stent with the non-compliant balloon in the LED. Then we made wire, we put wire here, we put the wire again in the diagonals, and first kissing balloon infection was done. This is the after first kissing balloon infection, this is the result. And then we remove the wire from the diagonal and put a stent on the main branch, LED. After LED stenting, this is the result. This is the result after stenting the LED. Then we put the again the rewired the diagonal and put NC balloon there, diagonal, and second kissing balloon inflation was done. After that, this is the result, and second kissing. After that, with the proximal part of the NC balloon, proximal already was, then pot was done. And this is the final result, you see. This is the final centrifugal picture. So there is limited data regarding bifurcation lesion in non ST ACS setting. DK crush has many steps, but can be challenging to perform in ACS setting. First kissing improve the stent expansion, and second kissing and pot maintain a better stent apposition. Post-procedural IVUS imaging should be done to see the stent expansion. So I am grateful to my professor, as Mustafa Zaman, and my teacher, as Dr. Mujib, my colleague Dr. Shaman Ahmed, for their inspiration and to allow me to present this case here. And this is all my presentation.
Thank you, Dr. Khaled, for your exciting presentation. Now I will invite Dr. Chayan Kumar Singha to present his case. Careful and sincere evaluation of a patient can avoid unnecessary treatment. Before that, I want to introduce Professor Safiuddin, who has joined us from far from USA. So can I please ask the technical team to
As the
add
panelist.
as the chairperson?
Yes.
Yes,
Yes.
he is already in our panel situation. He is already in panelist.
Thank you.
Thank you so much.
Dr. Chayan Sinha, please.
Sir, can you hear me, sir?
Yes.
Yeah. We can all hear you. Please
Okay,
start.
Honorable Chairperson, respected panelists, and learned audience, it's a big privilege and honor to present a case of the gathering and present cardiologist of our country. Today, I would like to present a very simple case, but
Please, sound is not good.
Sound commerce is done. Sound commerce is
এখন কি শোনা যাচ্ছে?
এখন ঠিক আছে, একটু কাছে এসে বলো, মনে হয় তোমার কি স্পিকারে সমস্যা হচ্ছে?
ওকে স্যার, এখন স্যার?
এখন ঠিক আছে, ঠিক আছে।
Okay. Sir, today I would like to present a simple case, but which is sometimes overlooked. My case, a 40-year-old gentleman who was non-diabetic normotensive, present to our emergency department in a tertiary hospital with simple severe chest pain and shortness of breath for the last 2 days. He was undergoing an ECG.
Sound is not good. Sound is not good.
Sound এখনো ক্লিয়ার হয় নাই, চয়ন। Sound is not clear. তোমার হেডফোনটা মনে হয় একটু বদলাইতে লাগতে পারে।
এখন শোনা যাচ্ছে স্যার? এখন
ক্লিয়ার, এখন ভালো। I think better.
Better talk louder, please.
Yes. এখন ঠিক আছে, এখন ঠিক আছে। Now you proceed, please.
Initial ECG was done, and by seeing this ECG, he was treated as a case of elevated MI, extensive antidote with thrombolytic and other medicine accordingly. But unfortunately, his ECG not so significant improvement, but he felt symptomatically improved. And his initial investigation was troponin was raised, but other investigation revealed no significant abnormality. And he was counseled for coronary angiogram, but he was not convinced. As a result, he was discharged on the 4th day without any further workup. 16 days later, he readmitted into our hospital with the complaints of recreational chest pain and shortness of breath, along with low-grade fever and cough. And on examination, he was febrile and heart sound was indistinct. And we very carefully looked his previous ECG, which showed the ST segment elevation was present in the leads on AVL and beyond to V6. And it is also present in the lead 2 and ST depression in the AVR with PR segment elevation and PR depression in the seen in the limb lead. So we assume that this was a case of pericarditis, and this is the ECG in our hospital which show widespread wave inversion. And subsequently that wave inversion became gradually diminished. And our routine evaluation was revealed. Yes, sir, 100 millimeter mercury in a millimeter in the first hour, CRP was raised, and the chest X-ray show globular appearance of the heart with cardiac shadow increased, and echo reveals moderate pericardial effusion with extensive fibrinous thread in the pericardial cavity. This is the cine image which show in the apical fourth chamber view showing the extensive fibrinous thread with pericardial effusion. And this is the focused view which shows the extensive fibrinous thread in the pericardial cavity. So our echo impression was this is a case of tubercular pericardial effusion. And accordingly, we proceed for pericardiocentesis pro subgyphoid approach, and 800 fluid was drawn, color was straw, and which was exudative with high lymphocyte count, and AD was raised. And we treated him with category on anti-tubercular drug with steroid in tapering dose for the tapering dose. And we followed up on month, and 1 month later patient was feeling better. The ECG was almost reduced normal, and the echo, we showed no pericardial effusion with good wall motion, and the ejection fraction was normal. And the echo change, ECG change in the pericarditis, there is usually ST elevation and PR deflation in the most of the lead, and reciprocal change in the AVR seen, and sinus tachycardia is common. And we know that classically pericarditis evolve in the 4 stages, in the stage 1, stage 2, stage 3, and stage 4. Stage 1, there is ST elevation with PR depression. Stage 2, there is ST changes with generalized TF flattening, and stage 3, flattening TF and inverted become inverted, and stage 4 becomes normal, which was present in our case. So my take-home message from this presentation is, every chest pain is not ischemic chest pain. Every ST elevation is not ischemic ST elevation. And proper history and clinical examination is very important to reach the diagnosis. Echocardiogram is a magical tool for diagnosis of the most of the cardiac disorder, like in this case. And every patient, it should better to do an echo in a hospital admitted patient in cardiology department before discharge. Thank you very much. Thank you for your patient sharing. We know that corona vaccine is not yet discovered. So mask is a vaccine, consider it, and we should always wear the mask. Thank you very much. Thank you for your patient sharing.
Thank you.
Thank you, Dr. Chayan, for your thought-provoking presentation. Dear audience,
I have one question to Dr. Chayan. That is actually very interesting cases. I have also a similar experience a long back when I was raised in Dhaka Medical College. But patient was not convinced for angiogram. But anyhow, before doing angiogram, usually what we used to do, at least on echo, is done after streptokinase. So initially there was no echo in the first admission period.
Dr. Ashok, can we?
No, sir. There was no echo was done.
After the presentation of our guest speakers, then we have ample time to discuss among ourselves.
Actually, what happened? The case are a variety of cases. So after all ending of all cases, the query will be less correlevant like this.
Please anyhow, write it down or give in the chat box because the speakers from the abroad will have to attend other seminars, so we'll let them free earlier. Okay, can I proceed forward, please? Dear audience, I know that you are eagerly waiting for the most illuminating part of the session. Now I will introduce in front of you our today's distinguished first speaker, Dr. Karthik Vasudevan, MD, DM, FICC, FSCI, Senior Interventional Cardiologist and Transplant Cardiologist at Columbia Asia Referral Hospital, Jaswantpur, Bangalore. Dr. Vasudevan graduated from Bangalore Medical College, had his MD in medicine from the same institution, got his DM in cardiology from Jaydev Institute of Cardiology, trained in heart transplant and envied in Methodist Houston Medical Center and J.C. Walter Junior Transplant Center, Houston, USA, trained in complex coronary interventions with Dr. Antonio Colombo at Milan, Italy, and C2 interventions with Dr. Imad Shivan, Turin, Italy. He is FICC, FSCI, and Fellow of Heart Failure Society of America, and is working in present institutions since 2008. He will speak on bifurcation, step-by-step strategy to decay crash. Please welcome Dr. Karthik Vasudevan, please.
Good evening, everybody. Thanks, Dr. Deepal Adhikari and Dr. Zaman for inviting me, and a very good evening to all the chairpersons and panelists. Am I audible and clear?
Yes, you are audible, please. And go ahead, please.
Thank you. So I'll be talking on mainly decay crash. And before that, I'll just give a brief approach how to approach a bifurcation stenting, and my special emphasis will be on the decay crush. So as we know, PCI affecting bifurcation lesions are encountered in 10 to 15% of the cases of our routine daily practice. So the inherent difficulty what we face in bifurcation stenting stems from the fact that after we implant the main branch stent, this can lead to acute impairment of flow in the side branch. And the true clinical relevance of the side branch is notoriously difficult to standardize because the side branch comes in various diameters, sizes, and it's very difficult to standardize. And apart from acute occlusion of the side branch, bifurcation stenting is also associated with increased incidence of long-term major adverse cardiac events, including stent thrombosis. It carries a poor success rate and worse long-term outcome if not performed properly. So these are the factors which we have to consider about the relevance of the side branch and the side branch diameter and length of the vessel, the angle between the main branch and the side branch, the amount of myocardium subtended by the side branch, the myocardial viability, whether there are collateralizing vessels or the patient has developed some ischemic symptoms after the occlusion of the side branch during angioplasty, and about the comorbidities and the left ventricular ejection fraction. And before we embark on bifurcation stenting, we have to assess the anatomy of the bifurcation. The first would be the assessment of the three diameters of the bifurcation. This anatomy is dictated by the main, if you look at the three laws, Finet law, Murray's law, and Kassab's law. The most common one what we use is the Finet law. The diameter of the main branch is equivalent to 2/3 of the diameter of the other two branches. And also it's very important to know the lesion length and the plaque distribution. And also we have to look into the bifurcation angle and the side branch ostium, especially bifurcation whether it's less than 70 or more than 70, whether the side branch ostium is involved or not. It's very important to decide whether it's a true bifurcation or a false bifurcation. So in a true bifurcation, both the main branch and the side branch are significantly narrowed. As you can see, in this true bifurcation, both the main branch and the distal main branch as the side branch are involved. And why it is important to know it is a true bifurcation? Because if it's a true bifurcation, the chances of plaque shift and the complications are much higher than if it's it's a false bifurcation. And also, if it's a true bifurcation, it's better to plan ahead and do a two-stent strategy. Whereas if it's a false bifurcation, you can do a provisional stenting and reassess the side branch and see whether it needs another additional stent. And coming to the classification of bifurcation lesions, there are so many classifications and they're all so confusing. So you have the Sanborn classification, Safian classification, Duke's classification, Lefray's classification, Medina classification, Moorhead classification. The commonly very easy and simple to use is the Medina classification, which is denoted by three numbers. The first number being the main branch proximal segment, the second number being the main branch distal segment, the third number being the side branch. So it is expressed as either Medina 111 or 110 or 101, depending upon the involvement. But this is not perfect. As you know that Medina classification assumes that any lesion which is more than 50% is taken as given a 1 score. But we know that so many times with the FFR and the OCT and IVS studies that the 50% lesion may not be hemodynamically significant. If you do an FFR, it may not be significant. So it does not take into the functional aspect of the lesion. The second thing it doesn't take into account is the angle between the main branch and the side branch. So it's not a perfect classification. Then we have the European Bifurcation Club classification, which is also called the MADS classification. M stands for main proximal first, and A stands for main across side first, D stands for distal first, S stands for side branch first. What it means is, it depending on the severity of the involvement of the lesion, wherever it is. If the lesion is very severe in the main branch, then you need to address the main branch first. If the lesion is very severe in the distal branch, then you need to address the distal branch first. And if it is more in the side branch, then you need to address the side branch and then proceed accordingly. So if in the the main proximal, you deploy the stent in the proximal branch across just before the carina, then look at the look for any plaque shift and involve the side branch. Then depending upon that, you can either do a skirt, and you can just deploy a stent in the main branch distal or the side branch, or you can do an extended V. If it is main branch across, that is the side branch is not that important and main branch is important, you just deploy the stent across the main branch, then do a side branch balloon kissing and reassess and see if it is flow is good and there is no compromise, lumen compromise, then you can just leave it at that. Or if there is a lumen compromise or there is a dissection or there is a residual stenosis more than 75%, then you can do an elective T-stent, indel crush, culotte, or a tap technique. Distal is a place where you get the distal main branch is more significant rather than the main branch. In that case, you can do a V stenting or a SK stenting. And suppose if you feel that the side branch ostium is more significant, there's hardly any lesion, this is not a true bifurcation, it's a false bifurcation, then you can do the stenting into the side branch first and then do a reverse side branch crush or the culotte or side branch mini crush. Then you can also do a T stenting mini crush or a DK crush. This is more exhaustive, but again, this doesn't take into account the angle and also the degree of stenosis. So this is the most three important things what you consider while doing a bifurcation stenting. This is the strategy given by Antonio Colombo. If it's a true bifurcation, that is significant stenosis on the main and side branches. If it's not there, then do a provisional side branch stenting. If there is it's a true bifurcation, then look for the suitability of stenting if the side branch is more than 2.5 or not. If it's not more than 2.5, just do a main branch stenting and keep the side branch open. If it's more than 2.5 and the side branch disease extends about 10 to 20 millimeters distally from the ostium, if it is there, then you do a elective 2-stent strategy. If it is not, then still you can do a provisional stenting. This is a very, very important diagram. See, on the y-axis, you have the side branch angle, and on the x-axis, you have the diameter. On the other side, you have the side branch obstruction. If the angle is less than 70 and there's more obstruction, then you have to do a DK crush, culotte stenting. And if the angle is more than 70, then you can do a tap, reverse tap, or just even a provisional stenting. And as the diameter of the vessel comes down, then it becomes, if the diameter of the side branch and the main branch is unequal, then you prefer mini crush or a T stent or a DK crush. For a culotte, it's very important that both main branch and the side branch should be of identical size. So this diagrams gives you a rough estimate depending upon the angle, the diameter of the vessel, and the degree of obstruction, how to choose an appropriate strategy. So the provisional stent strategy is the default strategy which is currently recommended, and importance is always given to the main branch stenting and optimizing the result. Side branch intervention is always not done if there is a dissection or a flow compromise or there is more than 75% stenosis of the side branch, then you do a 2-stent strategy. In the provisional stent, what we do is we stent the main branch and optimize the proximal part of the main branch with pot. Actually, we usually size the stent according to the distal part of the main branch. Then do a pot with a bigger balloon and optimize. So once you optimize, look for the flow in the side branch. If the optimal result is obtained in the main branch and the side branch flow is good, you just leave it at that. You don't do anything further. And if the jailed side branch deserves further intervention, then you need to do a side branch rewiring, then do a simultaneous kissing balloon, and then reassess, repot, and reassess, and look if the side branch result is acceptable after ballooning. I don't think you need to do anything further. Then if it is not acceptable, then you have to do a bailout side branch stenting. So this is the provisional stenting. So you do the main branch stenting, do a pot, then reassess, and if there is a compromise, then you do the distal rewiring and then do the kissing.
So if there's an extensive atherosclerotic involvement of both the main branch and the side branch, so and if in this case, if there's no risk of losing the side branch after main branch stenting, then you do the main stenting followed by planned side branch implantation. Either you do a T-stent, TAP or a cullot. If the major concern is regarding the side branch after main branch stenting, so straight away you go ARP on DK crush or do a first stent the side branch and do a then across the main branch. Or also you can do an inverse cullot, then inverse elective T-stenting, then inverse TAP. So this is the strategy what we commonly follow. And I'll now come to DK crush. I'll just concentrate because it's a very huge topic. I can't talk on all the techniques. I thought DK crush and Dr. Zaman's case was fantastic. Dr. Khaled presented a beautiful case, classical DK crush, fantastic result. I really enjoyed that case. So DK crush is very simple. If you one important thing I want to tell you is there are a lot of techniques, but one technique you hold on to it and you master that. And if you're good in one technique, most of the situation you can come out of it. So this is a cartoon depicting the DK crush procedural stages. So what we do is we implant the side branch stent, then we remove the balloon and the wire, then crush the side branch stent with a balloon in the main branch. After that, we rewire the side branch and do the first kissing. So once the first kissing is done, then we deploy the side branch, main branch stent. And once the main branch stent is deployed, then we recross the side branch again and do the second kissing and optimize the proximal segment with a pot. So these are the steps. It's quite step intensive, but of course, if you start doing, you become very familiar, these things becomes very easy. And now we got enough data that DK crush is the best stenting technique. In fact, in DK crush 4, it has even proved that it is better than provisional stenting. So with this background, I'll just present 2-3 cases and give an example how we do in different clinical scenarios, DK crush. So this is my first case is a 50-year-old gentleman who underwent coronary angiogram elsewhere in view of a positive TMT. He was diagnosed to have triple vessel coronary artery disease and was advised CABG. Came to our center for a possible PCI. He was not at all willing for CABG. Being young, he wanted to get an angioplasty done. So this is the angiogram, diagnostic angiogram. You can see there's a 70 to 80% lesion in the main branch just after the diagonal, and the diagonal has got a tight 90% stenosis. So we went ahead and of course RCA also there was a 80% narrowing. We later on stented the RCA. So since I'm talking about DK crush, I just thought I'll talk about the LAD. So what we did is we used angiosculpt. It's very, very important to prepare the bed. See, when we are competing with surgeons, it's very important we should give a very good result. And DK crush is the procedure which gives you a good result. And before we embark on stenting, we should prepare the bed very nicely. So we dilated both the main vessel and the side branch with a 3x10 angiosculpt balloon at about 12 atmospheres. Then we took a first stent was a 3x18 Xience Xpedition deployed in the diagonal. We kept a balloon 3x10 NC in the main vessel LAD. Then deployed the stent. After that, we pulled out the balloon and the wire. Then we crushed the first stent with the NC balloon. After this, we rewired and optimized the distal part of the side branch with a 3x10 NC at high atmospheres. We go up to 24 atmospheres. Then pulled it back. Then took another balloon 3x10. Then deployed, did a kissing at 14 atmospheres. So after that, we pulled out the balloon and the wire. Then we took a 3x32 Promus Premier in the main branch and deployed it in the main branch. Then we did a pot initially because there was a size discrepancy. We used a 3 balloon, so we don't want to get the wire below the stent. Whenever there is a discrepancy in the size, it's always do a pot in first and then do a repot later. So we did a pot with 3.58 NC proximally. Then we recrossed, then did the final kissing. And we dilated and we did the final kissing and then the repot. So this is the final result. So we got a very good result in this patient. So DK crush gives an excellent result, and if you do it carefully, it is one of the best stenting strategies. RCA, as I told you, we deployed a 3.5 and 28. This was later on in the same sitting we did. We finished RCA stenting also. So this is in a complex situation, a complex PCA where we did a rotablation to LMCA and did a DK crush to LMCA and did Ramus intermediate. This is quite important. Dr. Zaman, you can tell me if I'm overshooting.
Yes, I'm
Okay.
hearing everything is okay.
So yeah.
Right.
If you feel I'm
15 minutes actually are here, but everybody, but I think another how many slides actually you have?
Maybe another 2 cases. I'll finish it very fast.
Okay.
So
I think but we should listen to Karthik Vasudevan. Then we can discuss in short.
Yeah.
But let him
just
tell the in depth.
2 cases. Just
thank you, Mr. Adhikari.
No, you just show your 2 cases please early. Otherwise, will not be completed. Early,
Yeah.
you just show the slide.
Yeah.
Only angio show procedure.
Okay, sir. So this is a 77-year-old gentleman was admitted with CCF, known case of long-standing diabetes and hypertension, ischemic heart disease. 20 years back, he had undergone angiogram, showed mild CAD and was advised treatment. And after that, he was on medical treatment. He didn't bother much. Then when he came, troponin was elevated. ECG echo showed global hypokinesia, left ventricular ejection fraction of 15%, medically managed, stabilized, and taken up for CAG. Ours is a transplant center. We see a lot of these heart failure patients. And our protocol is to do an angiogram in all these patients.
So
and
your
look for
angio film you showed, that is better. How to
correctable causes. So this was the angiogram. So this guy had a critical left main and diffuse LAD disease. Long segment, right from the middle to the proximal, 90% narrowing. And you can see here there's a critical ramus intermediate lesion also. And circumflex was okay. And LAD, RCA had a subtotal occlusion almost. And myocardial viability scan was done. We had LAD was hibernating myocardium was shown. Circumflex in RCA was well preserved. And he was admitted actually for a bypass surgery. So, but of course, he developed a pemphigus vulgaris and CABG was deferred. And while waiting in the hospital, one morning he developed acute left ventricular failure, shifted to the ICU. We put him on NIV and IABP. Then surgeons refused to operate in view of his high risk and also skin lesions. So what we did is we electively planned for a high risk PCI with rota to left main and LAD with bifurcation stenting. The bifurcation strategy we thought of was DK crush. So this is the rota ablation, 1.75 bar. Sorry, 1.5 bar. We did a rota of the entire left main and LAD. The first stent we deployed in the mid. This is about 2.75 into 48 stent. Then this is the DK crush. We pre-dilated both the ramus and the left LAD and the left main, pre-dilated with the angiosculpt balloon. Then we put a 2.75 into 28 Xience prime in ramus intermediates. Crushed the first stent with a 3.5 into 10 NC. And then did the first kissing. You can see that. And this was done under intra-aortic balloon pump guidance because it was a severe LV dysfunction, EF of 25%. And whenever you're doing rotablation and severe LV dysfunction, it's better to have some form of support, either a balloon or a ECMO or a impeller. So after that, we extended the main branch, pulled out all the balloon and wire from the side branch, put a 3.5 into 28 Xience Xpedition LAD to the left main. Then we did a final kiss with a 2.75 into 10 in ramus and 3.5 into 10 NC in the LAD. Then this was a pot in the left main with a 4 into 8 NC at 24 atmospheres. And this was the final result. So this gentleman did well. In fact, his EF improved to, we did stage the RCA. So his EF improved to 35%, no admissions at all from that. He is doing fine. So you have got DK crush 5 trial, which has shown that DK crush is much better than provisional stenting. I won't go into the details because lack of time. Last case, I'll finish it off with this. This is a 60-year-old male presented with ACS, acute MI, no comorbidities, taken up for me. This is almost similar to Dr. Zaman's case. So this is the angiogram, LAD D1. It's a 2 bifurcation, Medina 111, almost similar to Dr. Zaman's case. But here, if you see, the diagonal branch is a bigger one compared to the LAD. So here, it's very important to choose which branch you're going to stent first. So because the diagonal branch was bigger, so after the pre-dilatation with a 2.5 into 15, balloon NC at 15 atmospheres, and the distal LAD we did with a 2 into 20 balloon. We put a 2.25 into 23 Xience stent in the mid LAD, then crushed it with a 2.5 into 10. Then after we removed it, this is the first kiss with a 2.5 10 NC in the diagonal. Then we removed the balloon and the wire from the main vessel, then put a 2.75 into 28 Xience V into the main branch, sorry, diagonal from the main branch into the diagonal, because the diagonal branch was much bigger than the distal LAD. Then this again pre-dilatation. Then we are doing the second kiss. Then this is a pot with a 3 millimeter balloon, 3 into 10. Then this is the final result. So this is in acute MI situation. So this guy also had a circumflex lesion, as you saw in the previous angio. 2 months later, we did an elective check angio, circumflex we fixed, and there's an elective check angio of the DK crush which we had done. And this is almost about 5 years now, he's doing fine. So my take-home message would be, bifurcation stenting is a totally different animal, needs meticulous planning. It's good to know at least one technique and master it. Provisional stenting must be the default strategy, as single stent is shown to be superior to 2 stents. When the side branch is important to preserve, upfront 2 stent strategy should be planned. DK crush may be a good option, and it's one of my favorite bifurcation strategies. DK crush trials have shown it's superior to pre-stenting crush, classical crush, then Coulot technique and provisional stenting. Thank you for your kind attention.
Thank you.
Amazing work done by Dr. Karthik Vasudevan, an excellent presentation by him. Now I have the opportunity and pleasure to introduce in front of you another renowned interventionalist from RN Tagore International Institute of Cardiac Sciences, Kolkata. He is Dr. Kuntal Bhattacharya. He had his DM in cardiology from Guru Gobind Singh Indraprastha University, New Delhi. Achieved various awards in academic career. He performed more than 4,000 cath lab procedures, including more than 500 PTCN radial femoral root, left main bifurcation, and primary PCIN by IVAS and OCT guided. He is actively involved in academic works and working in his current center since 2013. Please welcome Dr. Kuntal Bhattacharya with his topic ISR treated under OCT guidance. Please, Dr. Kuntal Bhattacharya.
Yes, sir. I think you can hear me.
Yes, we are hearing you.
Yes. So thank you, Dr. Adhikari, for your nice introduction. And actually, today's seminar, I think we are running late, so I don't want to. Can you see my screen?
Yes. Just go slide share, please.
Okay, please. So the nice presentation by all the presenters. Even in PAMI, we have seen 2 cases of DK crush, though my personal preference is always put a single stent. So we learned a lot. So my case, I will discuss a case of ISR and how our planning and management has changed after doing imaging. We have done maybe 50 or 100 cases of ISR each individual cardiologist has performed. But after imaging, I think the planning has been important thing is planning. Planning has been changed remarkably after imaging. So this is a case of 75-year-old gentleman with a history of PTC to LAD 15 years back, who himself is a doctor. Presented with high-grade angina, is ST depression in anterior lead in ECG, is preserved LV function. The biomarker were negative, and his COVID-RT PCR was also negative. So this is the picture, and this picture we can easily recognize the stent is cipher, and it is looking like well opposed and well expanded stent, except some middle part. But where the actual pathology we don't know. So I think we can plan. Now the plan is whether the drug-eluting stent or it will be drug-coated balloon, because nowadays drug-coated balloon is very much widely available with different sizes, and we know after several trials the outcomes are not so bad. So both are class 1A recommendation according to the guidelines, and IVUS or OCT should be considered to detect stent-related mechanical problem like stent under expansion or malapposition or any stent strut fracture. So imaging is a must now. So this is the meta-analysis of 10 randomized trials, DEDLOS, which shows the drug-eluting balloon is a bit inferior quality than the drug-eluting stent when we consider longer ISR than focal ISR. And though the incidence of MI and target lesion thrombosis are less in case of drug-eluting balloon vis-a-vis drug-eluting stent, but long-term target lesion failure is more seen with drug-eluting balloon. So these are the modalities which you can use. Only you can go ahead with your POBA. You can do a very high calcified new atherosclerotic lesion. You can take rotablation or ELCA help. Brachytherapy is no more a practice nowadays. Nowadays, most of the time we do drug-coated balloon, cutting balloon, or angiosculpt, and followed by our drug-eluting stent. So based on this OCT imaging, this slide is very important to know the pathology of the ISR. So pathology varies. If it is a early ISR and it is a very late ISR, the pathology varies. So the pathology depends on the stent drug failure. It is a homogeneous kind of neointimal proliferation. So probably it is a drug failure most likely in this patient, or maybe under expansion. This is a heterogeneous. Usually this kind of failure we see in long term or very late in-stent restenosis. This is typically calcium-rich neoatherosclerosis, and you can see the depth of the calcium is very well, almost it is 1 millimeter or 2 millimeter depth of calcium. So this type of lesion preparation is very difficult. Whenever we do or prepare a bed for a normal non-ISR vessel, it is very easy, because when you inflate the balloon, it expanded and you get the lumen at the cost of expansion outside of the vessel. But whenever it is limited by the stent externally, in case of ISR, even putting high pressure, you cannot achieve that lumen. So particularly this type of calcium is very notorious, and there is further chance of stent failure when you use drug-eluting stent in ISR, which is under-prepared. This is a lipid-rich neoatherosclerosis. This is a little bit easier lesion. How you can differentiate? Differentiate is both will cast a negative shadow, but there is no sharp outline here. In lipid core, there will be no sharp outline. In calcium, there will be sharp outline in OCT. So these are the common pathology of in-stent restenosis. Usually early in-stent restenosis was mainly due to stent failure, maybe due to edge dissection. So maybe distal reference area was not healthy and you have made a stent edge dissection. Or there may be a plaque at the stent edge. Whenever you are putting a distal edge at a non-healthy area where plaque burden is more than 40%, there is chance of ISR. Presence of thrombus, most commonly in primary. So under expansion is very common. So in these cases, the chance of ISR is also high, and stent fracture or strut fracture is definitely an important cause. So intravascular imaging actually helps to treat ISR and to plan your ISR better, because the acute gain as well as the follow-up preservation of the minimal lumen diameter is better if you take the help of imaging. These are the comparison of POBA versus paclitaxial coated balloon and drug-eluting stent in different group of patients. If it is a homogeneous or heterogeneous or it is a layered, whatever it is, your immediate gain with POBA is almost very good, but the long-term result is always better with drug-eluting stent. So my case, I have predilated the lesion with 1.5 into 15 millimeter balloon. Now somebody can argue that we should prepare, it is looking like 2.75 stent, so we can prepare a 2.5 millimeter balloon. But my intention was to see the actual pathology in the ISR. It is a diffuse ISR. So to pass the OCT catheter, I need this much of space. So I pre-dilated with 1.5 into 15 millimeter balloon at 10 atm, and this is the OCT run. The left panel shows the density and the lesion characteristic, and you can see, I will focus you. These are the homogeneous pattern, and this is the calcified area. You can see the large calcium. It is almost 380 degree calcium. So a bit deeper calcium. So you see this calcium is hard calcium. This is total 380 degree calcium. So when it is within the ISR and it is a new atherosclerotic calcium, getting rid with only your rota ablation is very difficult. Cutting with a rota ablation with such a deep calcium is very difficult. The second option is we don't have experience of doing IVL in case of stent, because we don't know how the stent will behave.
And Dr. Kuntal.
So this is the 2.7 into 10 millimeter cutting flexotome. Normally my internet is not stable. So normally we prepare our lesion with only 6 to 8 millimeter flexotome pressure, but as it is within the stent, so we can go higher. So still there is some dog boning, but it is looking like a bit better prepared lesion. So this is the OCT run just after cutting balloon, and you can see the balloon has done its job. It is very well cut, almost. This is the definite cut. These are the definite cut of the balloon edge. So, and now these are the cut in the endothelium. You can see very clearly it is seen in OCT. So I think with this type of cutting, we can achieve the lumen with further stent. It's a very beautifully cut in all the axes. The flexotome you have to use at multiple planes. So just beat a little bit rotation at each point is required. Inflate with 10 atm, take out 1 to 2 millimeter, then at a different axis you again inflate, so that the blade cuts at all the planes. So after that, with the proper lesion preparation, with the distal vessel diameter we have taken a 3 millimeter to prepare it. Now the dog boning effect is no more, it has gone. So we have taken a 3 millimeter into 38 millimeter Xience Xpedition stent, and always cover the distal edge of the stent. Even if it is looking healthy, don't leave at before the edge of the stent. Always leave your stent edge distal to your previous stent, at least 2 to 3 millimeters. So after that, post dilatation was done with 3.5 into 12 millimeters. The OCT run. So the OCT run shows good distal apposition, good lumen gain. The lumen gain is at medial edge 6.28 square millimeter, which is very much acceptable. You can see there is 2 layers of stent, and in between there is new atherosclerotic tissue. Excellent proximal apposition. So these are the final runs. So this is the treatment strategy for ISR. Whenever there is a ISR, always take help of your imaging, whether it is available, IVAS is available or OCT is available. Based on your imaging strategy, you take your plan. If it is a very focal ISR and it is a homogeneous, you can do, or vessel size is less than 2.5, another stent. Putting another stent could be difficult and it can cause more ISR. So go away with your just straightforward. You do your paclitaxel coated balloon. This gives good result. If it is a bigger size vessel, more than 3 or 3 plus, better you put your drug-eluting stent. The calcium-rich lesion should be prepared very well with scoring balloon or cutting balloon, whatever it is available. Sometime if it is a strain strut fracture, nothing can be introduced. In that case, you have to take the help of rota bar, and you have to rota or ablate the entire stent strut to get the lumen gain. So this is the concluding slide. Imaging should be used in all ISR cases to know the etiology, treatment plan, and procedural results. Choice of days versus drug-coated balloon depends on lesion characteristic, availability, and expertise. Patient should be counseled about the need of repeat revascularization, as TLR rate is almost double than the first PCI, which is 7.5% vis-a-vis 15% in case of ISR. And other form of revascularization that CBG should be discussed, particularly in left main and bifurcation lesion. So, thank you.
Thank you, Dr. Kuntal Bhattacharya, for your excellent presentation. Dear participants, now the session is open for discussion. You can put your question in the chat box, and our speakers, panelists, and chairperson will address them as much as possible. Now, I humbly request Professor Sufia Rahman to initiate the discussion, please. Sufia, madam.
Madam, unmute yourself, madam. Professor Sufia, madam. আচ্ছা আমার মনে হয় প্রফেসর দীপল ডক্টর
No, I want to give the floor to Dr. Ashok because I had to stop him earlier in the outset of the question. So can I ask Dr. Ashok to give his comment regarding the case of Dr. Chayan Sinha? Dr. Ashok, please.
Yes, thank you, Dipalda. Now, regarding Chayan Sinha's case, initially the patient was discharged without doing the echo. That I was asking. Yeah. So sometimes it happens that chest pain with ST elevation, streptokinase is given. That happens in my practice also once upon very long back. So initial echo is very much important for any STEMI patient or suspected STEMI patient, at least within 3 to 4 days during hospital staying. That I was asking.
This is a very important question actually. This message is actually, for that reason actually has presented this learning actually he experienced to everybody that this is very minimum investigation you have to done. Everybody should have done at least one echocardiograph, and without an echocardiograph nobody actually put the patient in cath lab. So this is for that reason actually Dr. Chayan has presented this case actually. He told me. This is learning.
Learned audience, now can I have the pleasure to introduce Professor Sufia Rahman madam. She is our grand teacher. She had many facets in her career. He was the professor and director at NICBD, Dhaka, and served the nation as advisor of the interim government. So she is our multi-talented cardiologist and is the mother of interventional cardiologist in Bangladesh. So can I ask Madam Professor Sufia Rahman to initiate the discussion, please?
Madam, yes, madam.
Yes, sure. Thank you for your introduction. The presentation was excellent. I mean, for a case presentation, let me start with the two presentation was very good, excellent, and I think you're doing very good job, and you know what you are doing. That is most important. And then the presentation from the abroad, the doctors from India, I mean, they are well known in their own field, and they are doing very well. The case was very good with the ejection fraction of 15, if I'm not wrong. After the procedure, what was the follow-up and what was the ejection fraction, I would like to know, but that was a really good presentation. And the last presentation is also by Bhattacharya is very good. I think there's all these case presentation and the both presentation, there's a lot to learn. For the fellows, no doubt about it. For us, is recapitulating all the points. But for them is so nicely pointed out what to do, what not to do for bifurcation lesion. This is very important. Mainly, one should do what is comfortable and knows the job, that what they have to do. Most important is already highlighted, and I have been always saying that where landing zone must be prepared properly, very nicely and properly, then your problem, half of the problem will not be there. If you half-heartedly prepare the landing zone, then you will most likely will end up in some sort of problem. So this is also highlighted. I'm glad it was done, and fellows should really make note of this point when you are practicing, when you are going to do it, if you have not done it, and if you are doing it, then it's very good. And you try to follow these points, and you'll have usually no problem. The restenosis is a nightmare for everybody. It's very difficult. When we didn't have IVUS and OCT, we used to balloon dilate if it is within sort of a 6 months or 9 months or a year. Then the cutting balloon era has come. After that, we did that. And if you don't have a cutting balloon, you can do a poor man's cutting balloon technique as well. I hope you know that put another wire and inflate a balloon and then try to cut it. That way you can also achieve some, no doubt about it. And very important is that putting one stent on there in restenosis, another stent is a you will end up again probably with is very important. When you put a second stent, you must cover your the stent length and go to the normal zone, and that is also important. I think these all is covered. I think I should let the others ask you question, and then you can satisfy their queries. For me, I can say that whenever you do, learn the technique properly, know what you can do, don't do any experiment, and then you'll be able to do it. And this is the way to treat our patients, to give them good life. And we cannot extend their life, but we can give the good quality of life to these patients. Thank you all the presenters, and thank you the organizers. All my favorite students are there. I really enjoyed seeing you all, and thank you for showing me the respect.
Thank you, madam, for your masterly comments. Your experience proved that you are really a master in cardiac intervention. So we are very grateful to you that you are present here, and will be till the end as usual. And you will hopefully conclude the session. Next, I want to go to other chairpersons like Professor Kim Fazlur Rahman. Sir is present here. So can you please, sir, unmute and say something about our presentations? Fazlur Rahman, sir, please.
Thank you
very much.
Yes.
Thank you, Professor Zaman and his organizers. Thank you also. It's a very interesting webinar. All speakers. Including our foreign speakers. So thank you very much.
Thank you, sir. Thank you.
Thank you, Rahman, sir, for your very brief comments. I know that you are to go to another meeting within 15 minutes, so you are in hurry. So I'll request Professor Sajul Banerjee, sir, to speak, because Sajul sir is also planned to attend that meeting. Can please, sir, Fazul sir, but he is very much friendly to all interventionists in our centers. and in other centers also. So he's very kind enough to attend us as a chairperson. Sajal sir, with all his limitations of health and business, has excitingly presented us with his amicable presence. So I will request Sajal sir to say something in front of this gathering.
Thank you, Deepak.
Yes, sir.
Respectable chairperson, Professor Subir Rahman, my most respectable teacher, and the other chairpersons, the panelists, the attendees, and the organizers, as well as the speakers from home and abroad. Virtually, what I have learned from this webinar that we must learn even after maturity from our pitfalls, from our some wrong things, like Chayan has told, and Khaled has admitted that imaging technique is very important, particularly in his limitation. Imaging technique should be in the cath lab, and that will be very helpful, particularly in intervention situation like decrash and everything. We must get help of imaging technique, particularly in Dhaka city. In the cath lab, we must have the imaging technique, and we must take help of those things in crisis, and we must be very much acquainted. The speakers from the abroad have given us a very clean-cut idea regarding decrash and another issue regarding the IRS. So I am very much benefited from this webinar. The speakers have presented very nicely. Again, I must pay my respect to my teacher and my panelists, the organizers, and the attendees. The moderator, Professor Zaman, and Dr. Dipal Adhikari. Again, thank you very much, everyone, and pray to Almighty for your good health and remain safe and safe.
Thank you, sir, for your blessings towards the interventionalist in our center and other centers in Bangladesh, because you all patronize all of them in very much enthusiasm. Now I will request Professor Chaudhry Mishkat Ahmed sir to say something about the presentations.
Dr. Zaman and Dr. Adhikari, sorry for interrupting. I need to leave. I have got one more meeting. I thank
Dr. Vasudevan. Dr. Vasudevan, sorry. Before you leave, there are some questions for you. So can you please answer this? And I'm reading the question.
Yeah.
It's from Lieutenant Colonel Nizamul Hussain Saudagar from CMS Dhaka. He wanted to know, in DK crash, is it always side branch first, then main branch, or any other opinion? Another question from the same.
It depends upon.
Can I cue the questions for you at first, and you then answer them all at a glance? The second question is, which classification, Medina or EBC, is preferred classification for bifurcation? These two questions is for you from Lieutenant Colonel Nizamul Hussain Saudagar from CMS Dhaka.
Yeah. See, whenever you decide on the DK crash, which we want to do the main branch, it depends upon the amount of involvement of the branch, the lesion, and also the size of the vessel. If the third case which I showed, the side branch was bigger than the distal main branch. So I put the stent from the main LAD into the diagonal. So it is very important to decide, depending upon the diameter, the amount of myocardium supplies, and also the degree of stenosis. And also, it's also important to decide on which branch you're going to stent first, depending upon the crossability of the side branch. Sometimes if you think that the crossing the side branch after putting the main branch stent is difficult, in that situation also sometimes we put the stent in the side branch first and then we put it in the main branch later. So it all depends upon the lesion characteristics and the importance of the side branch, the size of the side branch, and the amount of myocardium it supplies. Coming to the second question, of course, you've got so many classifications I showed you. Medina classification, none of them are perfect. To be very frank, none of them perfect. You have to take from different classifications. Medina classification is easier to follow. It's like a universal language. When you say 111, you know that the main branch is involved, the main distal branch is involved, and the side branch is involved. So easier to follow. But unfortunately, none of these speak about the percentage of stenosis, and it doesn't talk about the angle of the lesion, the bifurcation lesion, and also the length of the lesion. So when you look at that, when I showed you a graph where you take into on the x-axis you see the angle, on the on the y-axis you see the angle, on the x-axis you see the diameter of the vessel, and on the other axis you see the percentage stenosis. So all these three things you have to consider. When it comes to practicality, the European Bifurcation Club one is more practical because you look into the degree of the stenosis, you stent that, then depending upon that, you assess the side branch, and then depending upon the result, you decide whether you do a single stent strategy or a double stent strategy, and in double stent, whether to do a Coulard, tap, or T-stenting after you have stented the most critical lesion. So you need to take everything from good things from all the classifications and use it according to your advantage.
Thank you, Dr. Vasudevan. We are sorry that we had to say goodbye very early. We would be very pleased if you would stay with us till the end of the session. But sorry that you have to leave us. Then thank you from all this audience. Please stay well and stay with us also. Please.
Thank you very much, and I really enjoyed this webinar. I thank the Bangladesh Cardiovascular Research Foundation and the Department of Cardiology, BSSMU, and ABOT for giving me this opportunity. And hopefully we'll meet again. Thank you very much.
Thank you. Thank you. Now, learned audience, I will request Professor Chaudhry Meshkat Ahmed, one of our brilliant professors in home and abroad.
Dipal, before you proceed further, I think among the panelists, we have some very delighted interventionists are there. They are doing the DK crash and other things. And we'd love to hear from them what is their personal experience and what message they can.
Okay, sir. We'll not the stone unturned, because among us there are so many expert interventionists like Dr. Kaisar, Dr. Ashok, Dr. Selim. Okay. We'll of course listen to them, but as a senior to them, you are to bless them. So can you please say some words for them?
My take is from the Dr. Chayan's case, which was on echocardiography, which showed very rightly that every chest pain is not myocardial infarction and every ST elevation is not myocardial infarction. If we can remember the first ever streptokinase trial that was done in Italy, the GC trial, comprising about 33,000 patients, and there also they had some patients who were having the hyperrepolarization syndrome, the prismatic angina, and the pericardial effusion in their group. And it is so important to be methodical in every case. At one time, we had little resources, we had little training, and we had little education as well. But now we have everything in hand. We just cannot be casual about doing anything whatsoever. This is a great lesson that reminds us that we should never be unmethodical to everything. My question will be to the panelists, the bifurcating lesion, especially the left main bifurcating lesion, we have got different approaches. We have got different trouble with that, making with that. Some of us, we are doing that without having the intravascular imaging system. And do you think that if you do not have the real imaging in our hand, like OCT and the ultrasound IVAS, then it would be better to refer this patient if he's a candidate for CABG than to the CABG? This is my first question, will be to the panelist. My second question again to the panelist will be whether you require a very skilled hand to do that thing, because we know at present almost everywhere the percutaneous intervention is having the leading head, excepting the bifurcating lesion in the left main, where you really have to be very fine to contest with the CABG. So we want to take some message also that who are the real person and what will be the real justice to those patients who are having the bifurcating lesion in a real sense, in a real life. Thank you very much for giving me the opportunity.
Thank you, Mr.
I don't want to waste time. Just only one or two comments regarding Dr. Chayan's case. That's very interesting because we are always those who are cardiologists, particularly interventional cardiologists. We always try to do some interventions early, but we have to be very much meticulous in taking history also, not only echocardiography, also history, because in context of our country in Bangladesh, tuberculosis is very much prevalent, and we should take adequate history, like whether he or she has a fever or weight loss, anorexia, all the constitutional symptoms. So we should not hurry in taking the decision of interventions, and that's very important, including history, meticulous history, and echocardiography that may help us in taking the decisions. And regarding Dr. Khaled's case, very nicely done by Dr. Zaman. I must congratulate him. With the limitations, they have done a very nice case. And regarding Dr. Karthik Vasudevan and Dr. Kuntal Bhattacharya from abroad, their presentation were very nice and excellent. We learned a lot from both of them, particularly from Karthik Vasudevan regarding the case selections and step-by-step the procedure of Brigade class. But I want to make one more comment, that is actually by this webinar or by seminar or symposium, we are repeatedly listening and learning a lot. We are enriching our knowledge, but this is not sufficient. We will have to implement this. What Dr. Meskar just told, that actually whether we should refer the patient for CABG or where the facilities are lacking, whether we should refer the patients for CABG or not. I think actually, particularly in my center, BSMMU, I think now we are lacking behind because many centers we have the hardware, but still we are lacking in IVAS, FFR, OCT like this. So I think our our faculties and our young colleagues, they are very much efficient. It's not very much difficult to use these facilities. Just to procure these instruments, we can go in doing these procedures very much nicely, because we know that we'll have to do the port, we'll have to do the kissings, but what is the results of kissings? What is the results of port? Is it adequate? Is there any gap after port? Or is there neocarina formation is adequate? Or is there any strut malformations? To do these procedures adequately and nicely and effectively for the benefit of patients, I think all these instruments should be in our hand. I don't want to waste more time. Thank you very much.
Thank you, Shabuddin sir, for your brief comments, and thanks for your travels you took to join us from USA. Now, before going to the panelists, I have the honor to place the question from the same Lieutenant Colonel Nizam Hussain to Dr. Kuntal Bhattacharya. The question he asked was, who is option DES or DCB is superior to ISR management? Dr. Kuntal, please.
Thank you, Dr. Odhikari, to convey this question. This is a very common question where we should do drug-coated balloon and where drug-eluting stent. So my choice will be if you see a focal ISR or repeat ISR, that means you have done one stent, then you have done another stent, then triple jacket or triple layer of stenting is not possible. But that patient is also not a candidate for another way of revascularization in the form of grafting. So in this case, and when the vessel size is less than 2.5 millimeter or 2.5 millimeter, just 2.5 millimeter, so putting another stent will be difficult. In those cases, I prefer drug-coated balloon. And if it is a early stent failure, that means you have put the stent and within 6 months it is an ISR, and you have seen that your stent expansion is good, that means your drug is not working. And nowadays, you know, this no more there after taxus is withdrawn. Now all are with your sirolimus and everolimus, which are mainly water soluble. The paclitaxel beauty is it is a lipid soluble and it is it is actually a lipophilic drug. So if you put that drug inside, it will stay more longer period of time and the ISR will be taken care of. So smaller vessel, repeat ISR and focal ISR, I will prefer drug-coated balloon. And in all other cases, I will prefer drug-eluting stents like blood vessels, and those cases I will prefer drug-eluting stents. And if it is a main vessel like left main bifurcation and etc., so these ISRs should never be handled in repeat revascularization challenge. And we always straightforward refer this patient for CABG.
Thank you, Dr. Bhattacharya, for your wise answer. Dear audience, now we have covered all the questions put in my chat box. So we'll move to the next, to our panelists. Among panelists, there are renowned cardiologists from Dhaka. They all are well known to us and doing very well in their field. And among them, I want to invite Dr. Xience Nasrullah Khan, whom I respect to the depth of my heart. He is a very brave interventionist and doing a lot of cases and difficult cases, basically, who presented his experience also in abroad, especially in the neighboring countries, where probably Dr. Kuntal will be agreed with me that Xience Nasrullah is a pride for us. May I ask Professor Dr. Nasrullah to say something about the presentations?
Thank you. Can you please disable my video, because I can't start my video because host has disabled it.
Adnan, can you please disable his video?
His video is already disabled.
Okay. Okay, Xience, please.
Video. I can't start the video. I'm sorry. It's saying that you can't start your video. Yeah.
So maybe from
now.
Yes, now.
Okay.
Okay.
Assalamu alaikum and good evening to all. I would like to give my heartfelt thanks to the Bangladesh Cardiovascular Foundation and the Cardiology Department of BSMU for organizing such a wonderful webinar, and also my gratitude to Dr. Mustafa Zaman and Dr. Bifurcation, who are one is my younger and one is my elder brother, who are very wonderful soul to arranging to share this knowledge with juniors. Well, all the speaker has well said their talks. Khaled has given a good picture of a DK crash, which is very much trending now in interventional cardiology for bifurcation lesion. And secondly, Chayan also shown an out-of-the-box case, which we should all know that we should not only not think of intervention, but also think the other causes of ST elevations. And about the talk of Dr. Vasudevan from Karthik from Bangalore, who said vividly the different steps of bifurcation technique. But to make it simple, I would say that 90% of cases can be done with single stent strategy. Maybe 5 to 10% should be done for double stent strategy, where you can choose the technique according to your preference, or whichever technique you are comfortable, you should try that thing. And secondly, the ISR is a very hot topic because Dr. Kulton has presented his talk very vividly, giving the reasoning. And I say my fellows that when you do something, have a game plan, understand the pathology, what you're doing, and ultimately your technique, is it translating to a clinical benefit and long-term result for the patients? If you would have been the patient, what you have done for you. So understanding the pathology is very important. But having said that, I would definitely say that in a third world country like us, we can't afford to have OCT or IBUS in all centers. But definitely accepting those two high-end tools by clinical history or seeing the angiogram, we can have some idea, and according to that, we can plan our strategy. But definitely, if any ISR, I would prefer first to do plain balloon dilation, and then, sorry, drug routine balloon. If it is within the stent, I never choose to put second stent because it increases the amount of the metal as a second stent. But if it is in the edge, then I would prefer a stent. Otherwise, inside the stent, I would always prefer a plain balloon and then a touch of drug routine balloon for 30 seconds or 60 seconds, and that's it. But if it recurs, then of course, or if it does not open well, then of course we have to put second stent. Thanks. Thank you again.
Thank you. Thank you.
Thank you, Dr. Kaisar Nasrullah Khan, for your excellent comments about the presentations. Now I will request Dr. Dhiman Bonik from Heart Foundation. He is a senior consultant, associate professor there, and doing a lot of cases. He's a very gentle cardiologist, and I would say that we have learned many things from him. How a so big cardiologist may be so polite to his patients and his fellows. So I'll request Dr. Dhiman Bonik to address something towards the gathering.
Thank you, Bangladesh Cardiovascular Research Foundation and Cardiology Unit of BSMMU. I was a student of this Cardiology Unit BSMMU in early 2003 and 4 and 5. Respected teachers, colleagues and friends, thank you for me to everyone for giving me the privilege to talk something. Regarding the first case, this case was very nicely DK crash in a non-ST ACS setting. In non-ST ACS setting, DK crash can be done. It can be done. In DK crash, the important things that I want to add something with this in this gathering is that DK crash is the procedure in which the wire of the main branch is never removed. So it is very safe for the patient as well as for the intervention cardiologist. So this is a very important. A DK crash is the main important tough thing for DK crash is that wearing for 2 times, and this is this should be to me. I want to say something that rewiring should be done in our cath lab with N-wear, that is new wear. If you have a new wear in your hand, you can recross the stent starts easily. But with the old balloon and wear, sometimes it may be difficult. And the second case of Dr. Chayan, this is it is a very nice case. And to me, I want to add something to this presentation, very nice presentation. In my clinical practice, in my hospital, if a patient has got pericardial effusion, before doing an CAG or PTCA, I am very alarmed. I always, in minimal to mild, I did the case, and I do the case even with low heparin and gradually giving heparin in PTCA, because in CAG or PTCA, you do not know what will happen. You might need for giving integrin, the active glycoprotein. So then if the patient is pericardial effusion, then the patient will be, it is a nightmares for you and as well as for the patient. I think so. In this case, if echocardiography is done earlier, then this would be an open case for this case. Will be straightforward rejected for the first time even. And for the Dr. Karthik third case, is it be said that is a reverse decay crash? There is a term that is reverse decay crash. I think so. It is the reverse decay crash where the first stent was given to the LED and the second stent, main stent, was given to the diagonal. I think it is the reverse decay crash, and the ISR case was very nice. I have learned a lot. Today's Friday evening is very nice for me. I enjoyed a lot. Thank you all for patience hearing.
Thank you, Dr. Dhiman Bonik, for your excellent comments for the speakers and presenters. Now I will introduce the genius cardiologist who is very sound academically and doing tough cases, doing lot of cases, but at the same times has tremendous effort in academic activities in National Heart Foundations, working as a state professor and senior consultant. Dr. Ashok Datta, can you please unmute yourself and say something about this session?
Yeah. Thank you, Dipalda. Thank you, Bangladesh Cardiovascular Research Foundation, Dr. Mustafa Zaman.
Thank you.
And I definitively pay my regards to my teacher, Professor Shajal Banerjee sir, Professor Supiya Rahman madam, Professor Shafiuddin sir, and my direct teacher. He was my register, and I can still remember his advice and his all the things that he taught me in about 30 years back in Midford Hospital. Professor Meshkat Ahmed sir. He is a very talented man. Till now, the person or teacher that I met, I can remember him, his advice till now. And anyhow, regarding all the cases that are excellent case, regarding the Xience case, I was talking that this type of case, sometimes we try to hide something, our fault, but he exposed it, and that mistake that was done, that is the great learning for all other juniors. So that is a great thing. Chayan, this is a great job you have done. Dr. Khaled case was very good case for decay crash in acute coronary syndrome. If the thrombus burden is not there, then decay crash can be done. But if there is thrombus burden, definitively decay crash should be avoided, and single stent strategy followed by subsequently the side branch is needed to be treated next 1 or 2 days later, that can be tackled. Dr. Kuntal described all the cases of bifurcation lesion very brief, nice way, and Dr. Karthik case also very important. ISR, basically the ISR and distal left main, what Meshkat sir was telling, distal left main by stenting, if it is single stent strategy without compromising the circ, or if the circ is small non-dominant, then the thing is different. Otherwise, distal left main really very tough job. The same thing is true for ISR. It is very difficult thing to deal with suboptimal result, and subsequent stenosis rate is very much high. So I again thanks the organizer for this nice session they have arranged. Thank you.
Thank you.
Thank you, Dr. Ashok Datta, for your nice and kind words. Now I will request Dr. S.M. Ahsan Habib, who is Associate Professor of Bangabandhu Sheikh Mujib Medical University in Department of Cardiology, and who is doing a lot of cases there, and is also a very keen educationist.
Dr. Ahsan Habib, here.
He is not with us right now.
I think he is
not
here. Dr. Mustafa is here.
And Dr. Mustafa Rahman is
not here, maybe. I'm not sure.
Abu Salim.
Abu Salim.
Then I will request Dr. Abu Salim, who is also Associate Professor in Department of Cardiology in BSM, who is doing a lot of tough interventions, who has made his place in the interventions of Bangladesh. So he will sum up the cases and presentations to us, and he will be the last panelist in our session.
Thank you. Assalamu alaikum for giving me the opportunity to speak something, and especially thank to Bangladesh Cardiovascular Research Foundation. First, Dr. Khaled's case. Just one thing I want to know, that what was the size of the balloon in decay crush, the first kissing and second kissing. I want to know from Khaled that is there any difference between the size of the balloon between first kissing and second kissing? It's a case was nice, excellent case, outcome was very good, and flow was better. So my focal point is to whether we should go for it same size of balloon, and is there a same size? Is there a difference in the inflation pressure in the between first kissing and second kissing? And case was done excellently. And about the second case of Dr. Chayan, everybody tells that this is it opens our eyes to do an at least echocardiogram before discharge. If any patient admitted into any hospital for in cardiology department, we should do at least an echocardiogram to check it before discharge. If it is done before discharge, in this case, this scenario would not be happen. But it opens our eyes to do an echo for every cases. And about these foreign speakers, Dr. Karthik is elaborately present the different techniques and steps of decay crush. But one thing I will not agree with him. He presented, speaks 2-3 times that decay crush outcome is overcome, but a better outcome than the provisional stenting. But I agree with Dr. Kaisar Nasrullah sir that provisional stenting is still 90% cases is more preferable. But he mentioned several times that decay crush, if can be done better, it is a good outcome, even better than that of provisional stenting. But I am not totally agreed with that. Another presenter that about Dr. Kuntal Bhattacharya, he speaks about OCT, use of OCT or in imaging in ISR cases. Very good and elaborate thing. It opens us. It gives us idea the mechanism, and if we know the mechanism of ISR, it is very easy for us to plan for the management, whether balloon, whether we cutting balloon, rota, or simple plain balloon. That is a very nice case, a nice presentation. We have learned a lot from that cases, and thank you again for all panelists and the organizer to arrange this session. Thank you.
Thank you, Dr. Abu Salim, for your extensive observation regarding the cases. Now, I think.
Can I,
sir,
Dr. Deep,
I am
can
giving
I
you
add
the
one
floor.
point?
Professor Shabuddin, I think want to put some comments. Sir, please.
just one comment regarding Professor Dr. Salim's comment. Actually, what Dr. Karthik Vasudevan told, I agree with him, because what I understood, Dr. Karthik told that whenever there is many twist and strategy necessary, then decay crash is a very good options than other options. But definitely, provisional stenting is good. Definitely, in most of the cases, provisional stenting is better. But when twist and strategy is needed, then decay crash is the method of choice in most cases.
He didn't say like that.
Thank you.
He said definitely that even if we do decay crash well prepared, that it is result is outcome in different studies shows it has better outcome than even that of provisional stenting.
So
okay, probably I could not understood his comment.
There is something communication gap. Actually, what the Shafiuddin sir was telling, that is true. Single stent strategy is better, and among double stent strategy, decay crash has got better outcome except short and long term thrombosis, stent thrombosis. Otherwise, decay crash is better than tap and pull out and others.
There is a multiple stent, the decay crash is better.
Zaman, please unmute.
I'm adding with Dr. Ashok Datta. Actually, every performer has a comfort zone, so it depends on the performer. So, but the study actually reveals that according to Dr. Ashok Shed have mentioned that decay crash points, favoring point is more than other, but it depends on the performer comfort zone, I think so. But it should be varied maybe, but it is not actually debatable. So sometimes, suppose in decay crash, if the if single stent strategy in case of bifurcation lesion, sometimes actually the ostium of the side branch may be pinched, and that time may be very difficult to rewiring the side branch, and then tap is the a good option. But sometimes some performer do reverse culotte, and in the book lot of method may be written, but it depends on actually a performer, because the patient is the main actually issue, not the lesion. So it depends on the performer. I think so. This may be debatable. Our actually, I have a question. Another in case of the bifurcation lesion, in especially decay crash during wiring, rewiring. Already Dr. Dhiman Bonik and Dr. Ashok mentioned, and Dr. Kasan also mentioned that. But during rewiring, the proximal strat and the distal strat. We know in decay crash, everybody like the proximal strat during requiring, and Dr. Dhiman Bonik also mentioned that, and Dr. Kaisarla also mentioned that the new wire. But what's the difference between the proximal strat and distal strat in case of decay crash? Dr. Ashok Datta, can you mention, please?
I don't have that picture. Initially, in decay crash, you have to cross through the proximal strat or at least through the mid strat, not distal. Suppose we cross it after putting the LCX stent, we crash it, then we cross the distal strat. Then two difficulty may happen. First, to put the for inflation, balloon will not go through this distal strat because it is angulated and it is outside the strat actually. Second thing, even new balloon may enter into the LCX, but that will make a gap at the distal proximal part of the LCX. So that part will remain bare. That part will not be covered by the stent. So two things will happen. On carina, will not be formed oil. Second thing that may happen, the balloon crossing will be difficult. So why in decay crash always proximal?
Exactly.
Or at least if proximal not feasible, middle strat should be recrossed so that carina in subsequent oil, carina is formed oil.
Can I add something? Can I add something to this?
Dr. Dhiman, can you please wait a bit because our senior Professor Mishkat sir want to add something. I think he should speak first.
No, I had different context. Possibly Dhiman was in the context. My context away from the intervention. That is about the Dr. Chayan's case. The case that Chayan has presented, it was also showing fibrous band in the pericardium. So this is the patient actually to be followed for constrictive pericarditis. This is one thing to be brought in the mind. So all eyes are on the intervention, and possibly I'm the only person relatively non-interventionist.
So, Mr. Sir, I actually today I also faces one patient with such pericardial effusion. What to do to prevent the constriction or constrictive pericarditis in long term? Steroid usually we stop after 1 to 2 months. Is there any role of methotrexate or some antifibrotic drug or anything?
Probably we we cannot do anything to prevent the constrictive pericarditis. But main thing is to observe whether the patient is advancing toward the constrictive pericarditis. And once he has the constrictive pericarditis, then surgery is a very good option. No drug actually.
Oh yes.
Sir, can I say one thing, sir?
Turn.
Sir, we know that the steroid should be given 1.5 months in every where we can use. But in Davidson, it is written that in tubercular pericarditis, the steroid should be given at least 3 months in the tapering dose to prevent the constrictive pericarditis. So we can prevent this.
Yeah, John, you wait a little bit because I'm to stop everybody because our chief organizer, Professor Mustafa Zaman, is to leave earlier for another meeting. So I will request Professor Zaman to say goodbye to us, and then we'll have ample time for discussion because Professor Sufyan is still with us. So I am requesting Professor Zaman to say the goodbye to all audience.
Hello.
Professor Zaman, please unmute and.
Yes. Thank you, Chairperson, especially Professor Sufyan, Madam, Professor Shajol Banerjee, Professor Fazur Rahman, Professor Meshkat Ahmed, sir, and from USA, Dr. Shobidin sir. Already they have contributed to this seminar, and our especially to speakers and to presenters actually, and our panelists, they have actually contributed a lot of things, and we have learned many things, and especially I must thanks to everybody, and especially I have nothing to say, and we'll continue this type of webinar, and I hope everybody will help us. And I want to say our chairperson, especially Prof. Sufyan Rahman, to conclude the session. I must thanks to Professor Sufyan Madam also.
John, before concluding, I think there are some opinions.
Okay.
I think that should be resolved, and then I will give the floor to Madam.
Very quick response to Chayan's answer, because the case that he was dealing was a little late case. When you have pericardial effusion early in the disease, then you can give steroid. But once the patient has developed fibrous band, it has gone a long way, and in that case, it is not going to do any benefit.
Thank you. If actually I have another program in Prathamalo with World Hypertension Day, so actually I'm leaving now. If everybody permit me, actually I'm ক্ষমা প্রার্থী যে একটু আমাকে ক্লিপ করতে হচ্ছে যদি সবাই অনুমতি দেন। ম্যাডাম একটু যদি মনে না করেন ম্যাডাম।
Now I will hand over the floor to Madam. It's up to Madam whether she will conclude or continue for some time regarding the last issue. Dr. Dhiman, Madam, Dhiman da কিছু বলতে চাচ্ছিলেন ওনাকে বলে তারপরে অশোক মনে হয় কিছু বলতে চাচ্ছিল ওটা বলে তারপরে আপনি একটু
না let him say যে এগুলা প্রোগ্রাম করে if you don't have satisfy or if you don't have the answer what is query, I think you should let him say something, that might help us.
Dhimanda, please.
I want to add something to Dr. Ashok Das recrossing. It is absolutely correct. In decay crash, stent starts because recrossing from proximal or for the middle start because the angle is less. The angle is less. If we cross from the distal start, the angle will not be maintained. In case of culotte and a tap, the angle is more than 70 degree. So we should recross from the last start. This is the difference. The carina should be well maintained with the crossing the stand start. In decay crash, it is always with proximal or in the middle, and in pull-out or tap, it is from the distal start. Thank you.
Thank you, Devanda. Ashok, will you say the finishing?
No, Devanda, thank you, Devanda. Actually, I will request Sudhya Madam to give us some advice regarding ISR, because we are fortunate that we are now getting the DES, even a better generation of DES. But when Madam used to do the PCI, that time only the bare metal stent was available. So I think she is the best person to give the opinion regarding ISR, Madam.
Exactly.
Okay. Madam will encompass everything in his conclusion. If not anything from other panelists, I will request Madam to sum up, wind up the session, and conclude it also.
Madam, bare metal na, Madam শুধু plain balloon করতেছে, তখন স্টেন্টও ছিল না। When she started doing PCI, তখন কিন্তু bare মানে বেইল আউট প্রসিডিউর হিসেবে স্টেন্ট ব্যবহার করা হতো। ম্যাডাম নিশ্চয়ই মনে আছে।
আমি একটু বলতে চাই 10 সেকেন্ড, একটু যদি সুযোগ দেন।
জি সরিম বলেন।
আমি মানে আমার প্রশ্ন ছিল যে ধীমানদার কাছে, অশোকদার কাছে ওই যে ফার্স্ট কিসিং আর সেকেন্ড কিসিং এর সময় সাইড ব্রাঞ্চে যে বেলুন দেই, সেটার প্রেসার কি আমরা কোনো ডিফারেন্স থাকে ফার্স্ট কিসিং আর সেকেন্ড কিসিং এর মধ্যে? ইনফ্লেশন প্রেসার
ফার্স্ট কিসিং যেটা হয়, ফার্স্ট কিসিং এ ইউজুয়ালি যেটা হয়, একটা one balloon is inside the stent, other balloon is without stent in the main vessel. So this time pressure should be 12 or 14. But in the subsequent kissing, when the both stent is there, within both stent, we can go up to 18 atmosphere. So first kissing should be more gentle, but in the last kissing, that may be at high pressure. Simultaneously, up to 18, even 20 sometimes we used to go.
Thank you.
Madam. Madam, please conclude the session. Adnan. Please unmute. Adnan, are you here?
Yes, sir, I'm hearing.
Please unmute, madam. And
Madam is already unmuted, sir.
Okay, madam, please.
Yeah.
Madam, please say something. You are already unmuted.
Well, yeah, thank you. I cannot see anybody now. There's no video. Anyway, thank you. I'm always interested to see what you people are doing. What I was doing is much more different. You see, the life here now is much better with the imaging, no doubt about it. And if you, those centers like BSMU, I told your VC also that to get you the things you don't have, because university should have all these gadgets, all these hardwares, so that they can be trained and they can be placed in different places in the interventional cardiology. See, life is much easier now when you are using IVAS or OCT. Then you know what sort of lesion you're dealing with. Before we didn't know, and when we only the fluoro and the imaging was there, that's all we had. But now you can see what you're dealing with. You can prepare the lesion, you can treat the lesion, single, double, stent, who knows, whatever is needed, you can do it so nicely. And I think this teaching should go, and you should do it, because in Japan you've seen that they do every cases. IVAS, OCT, without that they don't do mainstem. So like that, and that's why their results is so good. So I think if we start also, if we want to add anything in the cath lab after the echo machine, extra, that it should have these either IVAS or OCT. And training people with the eyebrows OCT is not a great deal, and it can be done very quickly also. And the caliber you people have, it will not take long time. So I think we have to start the teamwork to have this imaging, which will be really helpful for our patient and for our long-term result. I wish all the centers will have it, those who are using bulk, and those don't have the facility and won't be able to do it, please refer or ask your seniors, those who do it, or go to their center with the patient and do it there. Then that way also you can learn. But our centers are not like that they will allow you. But I think for teaching purpose, they can allow always the cases. This is a need broad-minded, and for teaching purpose it should be done. And coming back to what we started, yes, I remember when we started, we used to do only plain balloon. The stent was not there, because you know that the stent came in the market in 1977. And we got it late in 90s. So there is a difference of 20 years it took to come to Bangladesh. Anyway, when we used to do plain balloon, and after that the era of stent came, and we used to do the stenting, that also bare metal stent and not mounted in the balloon that you are seeing these days. They were only bare, you have to mount it and then you have to place it. So those were very tricky days, and there were only J&J had the crimping machine. Other than that, the rest of it you have to do it with your both fingers, put the stent on the balloon and then crimp it gently, nicely, roll and make sure the stent is properly crimped. But the result, if we say, I surprised, after 20 years I see somebody, and 15 years, 17 years, those bare metals are still intact, no instant restenosis. They are coming back. I've been following few of them, but most of them, those who are still alive, coming with a new lesion in the coronaries. That is a different issue, because sometimes I tell my cath lab staff, you see what we did 17 years ago or 20 years ago, you see they are intact and there is no restenosis, but you got the stenosis in other vessel, and we are doing with the modern stents. This is also, like everything, what when in our childhood, what television we have seen, black and white, and some of them was run by the batteries even, and now you see you've got the digital television. So likewise our technology has also improved, and where we are now, we have got all the manpower, we have got the center, and we need hardwares to give it to the centers where they can train the juniors and they can make the job perfect. And I'm sure with the authorities, we can convince them, then they will definitely provide us it. In your university, if you need, your VC is very well known to me, and he respects me a lot, and if you need, I will go with you to request him what to get you quickly so that you can get it and start the service. Presentation wise, really, and discussion was more fruitful. You see, the DK crash is definitely now and again it will come, because it's coming up. But for the provisional stenting and the DK crash, if you head to head, if you really compare, for our time it was in provisional stenting, no doubt about it. Now with the imaging and with the rotablation, with the stent, all these DK crash is coming up. So how you will do it, what you will do it, all depends on your training and the lesion preparation, and then stenting it, and make sure after finishing it, that you have done proper job. Here the nightmare is the restenosis or thrombus formation. That's why. So anyway, I don't want to make it long. I have to rejoin the other meeting as well. Thank you again, the organizers, Deepal, and all of you. I think Mustafa Zaman has gone to another meeting. So all of you, Meshkat, and then all of you from your university staff, cardiology, thank you again for having me, and really nice to see you. I'm proud of you, all of you. Thank you.
Thank you, Madam, for your illuminating conclusions. Thank you all, everybody staying with us. Hopefully we'll meet very soon. Till then, stay well and best wishes for everybody. Thank you.
Thank you. Thank you.
Thank you, Dipal.
Thank you, Dipal. Sir, thank you, sir. Sofruddin, sir, thank you, sir.
Thank you. You're welcome.
Thank you, Diman. Thank you, Ashok.
Madam, thank you. Madam, thank you.
Shafiuddin has gone to America. I didn't know. Nice to see you. You're looking better.
Thank you, Madam. Assalamualaikum. Madam.
Iman and Ashok, thank you so much for joining the meeting. Thank you.
Madam, thank you. Madam,